Guys, a very good evening to everybody. Wishing you a happy Holi in advance, and we can get started for a quick recall for today. So, the main objective would be, though I think a lot of questions would be having overlap and would have been discussed, but I'll give you my take on it, and I'll give you a couple of references also, so that all those controversies which are supposedly, being said about a particular question can be resolved. So, very good evening, Dr. Vakar, Dr. Raj, Dr. Raj Gautam, Dr. Priyanka, Dr. Asik. So, in case I missed out a couple of names, really apologize, Dr. XYZ, Ravi Raj. So, very good evening. Thank you, Dr. Rupa and Ajit also. So, I think you guys would be pretty relaxed by this particular point of time and would be wondering that how much time do we have at our disposal at the moment, considering that a couple of days ago, it was like a shortage of time and you had so much to cover. But that's the part and parcel of being a doctor. Okay, very good evening, Dr. Anya, Dr. Hassan. Yep, you will do great. Thanks, Shivam. So I think it's time to get started, and we try to hit the nail on the head. That's the approach now, and you would be able to do great. Okay, happy Holi to everybody. Let's get started with the first question, which talks about this patient who's having blood pressure on the higher side. I think from the recall option, the blood pressure values are pretty fine. 160 by 110, and then the CT head of the patient, subrectal hemorrhage is detected. Doctor, we don't, okay, somebody said mannitol also, so I'll just say one very basic fact that in patients who are having subrectal hemorrhage, the primary objective would be two. One would be to take care of whichever aneurysm that has ruptured, and second would be to prevent the delayed cerebral ischemia in the patient. Yep, some people are saying conventional angiography for the aneurysm. So I'll just give two references. First and foremost would be like, this is what is the main video also that we've discussed, that first you do a plain CT and after that you do a CT angio. Now, why do you do a CT angiography? Yes, doctor, it was the word. Okay, next step or immediate, I think both would mean the same. So not too much of a difference, but yes, urgent surgical intervention is also coming. So we have to do a surgical intervention in a patient. But if you go through the main video, what I try to emphasize is you do a CT. If in case you don't have a facility for a CT, you can do a lumbar puncture and then you do a angiography. Now, why you do this angiography? There are two reasons I can describe. Dr. Faisal, that SDH question was different, so let's focus on the job at hand. Quick intro for into 30 seconds into why we do angiography here. First would be, suppose a patient is having more than one aneurysm. So we want to know that there are, let me say, 2, 3, or 4 of them. So we need to clip them, possible. Second would be to differentiate whether it was berry-aneurysm. Yes, Nikhil, that is what I'm trying to explain to you. We have to give nimodipine, but the point is nimodipine is used to prevent delayed cerebral ischemia. The peak of delayed cerebral ischemia does not develop immediately, but develops between 48 hours to 7 days. I repeat again, why the answer is not nimodipine is because the cerebral vasospasm is not present immediately. The immediate threat is rebleeding. The immediate threat is not a vasospasm. It develops after 48 hours to 7 days. That's one point. Second, why do you do angiography in a patient? I have explained that in the main video. I'm repeating that once again. First point is, the advantage of doing an angiography would be that you will be able to tell whether it is a berry-aneurysm versus a presence of a arteriovenous malformation, because the treatment for two and the approach for two will be different. Second is, think from an Indian patient's perspective. You are telling somebody's family member that, okay, the person had a rupture of a berry and this was at the left anterior communicating artery joining with the anterior cerebral. Relative might say, sir, maybe it is more than one. Can you be sure? So suppose one has ruptured and the second one has not ruptured. The critical size is usually more than 8 millimeter when it begins or tends to show a rupture. So I want to be sure whether there is an unruptured berry, because we can clip it there as well. So point number one, I'll repeat that once again before we yes. The main point which I'll say would be number one, why we do aneurysm, and I'll give a reference from Harrison also. It's not that, it's just that I am saying it. This is what Harrison has mentioned, and this is what is given in your main notes. This is given in the main section in the app. Point number one, there can be more than one aneurysm. Point number two would be that we want to differentiate whether it is aneurysm versus arteriovenous malformation, because the approach for both of them would be grossly different. This is a reason why the answer for this question would turn out to be option number Bombay, as I have mentioned here. Just zooming out to the slide. So for those of you who joined late and people are saying, okay, why not answer nimodipine? I've already explained. It's used to prevent delayed cerebral ischemia or vasospasm. Vasospasm takes about 48 hours to 7 days to peak. So that's the reason for the answer to this one. Slightly a difficult one, I would say, toe crushing Yorker, as they say. But the second one was a much easier one. Hello, Shri. Very good evening. Murmur shown here. You can see that the intensity of the murmur given in the description is almost the same. In case we were having a murmur which was rising in intensity and then the intensity was falling, then we call it a ejection systolic murmur, and the approach would change into thinking in terms of a valvular aortic stenosis. But considering that the intensity in this particular case is uniform, right from the starting of the systole right from S1 going up to S2. So this would be a classical presentation that we get with a patient who would be having mitral regurgitation, or it could be a ventricular septal defect. So it's just that it's a mixed bag of questions, one a difficult one, a second would be relatively easier one. This would be a pansystolic murmur. Hi Rahul. Moving to the third one, this mentioned about a patient who is having chest pain, and that's radiating to the interscapular area. I mean, I've highlighted this statement multiple times. Every time you read about a patient having an interscapular pain, you always need to think in terms of, I mean, every time you read interscapular area chest pain present in a person, first differential that should be kept in mind is valvular aortic dissection. And another point would be that the blood pressure of this patient is turning out to be unequal, which is again because of the antegrade progression of the tear per se. Hi Rishabh, very good evening. Yes, Raviraj. Let's rule out the other options. Pulmonary embolism will present with breathlessness. There's no hypercoagulable state present in this particular case and would not be having unequal blood pressure. Takayasu's arteritis can result in unequal BP, but then when it comes to Takayasu's arteritis, it would be having more of a chronic presentation. It might present as renal artery stenosis. It might present as arm claudication in a person. So considering that interscapular pain was described and it was an emergency presentation, the first clinical, I mean, diagnosis for this particular case would be given as option number B. Okay, one option was esophageal rupture. Okay, doctor, I'll incorporate that subsequently. Though I strongly suspect that it might be mixed up with some other question, but then it's okay. Thanks for the inputs in this particular case. I mean, Takayasu presents as mainly arm claudication because left subclavian artery is the one which is usually involved in this case. So yes, it also has unequal blood pressure, but since we have the options here, we would be able to work it out. Okay, instead of Takayasu's arteritis. Okay, thank you, thank you. So in esophageal rupture, doctor, we'll have macular striate. And Ashu says that is pain radiating to the interscapular area characteristic of aortic dissection? I would not say that, but then we don't read about interscapular pain with standard cases of myocardial infarction. So I'll not say that that's a very good point from diagnostic purposes, especially in a setting of evidence-based medicine where patients will ask you so many questions. But from your MCQ perspective, yes, I mean, I've emphasized that any MCQ that begins by describing chest pain and then interscapular pain, you be assured that the majority in majority of scenarios the patient's pain would be, I mean, the cause of pain would be aortic dissection. As far as esophageal rupture is concerned, you should be having macular striate. There should be information with respect to subcutaneous emphysema in a patient which was not given, or crepitus over the chest wall. So considering those two scenarios, I'll be pretty comfortable ruling out I mean, esophageal rupture as one of the reasons behind why this would happen. And moreover, you know, a person should be having, like if the question began by saying alcoholic, protracted vomiting episodes, and there's a retching, and then there's going to be a rupture, that would go more in favor. So I think we're sorted with the question number 3, aortic dissection, pretty straightforward one. Thanks for the inputs here. The fourth one talked about the smoker with pain in the arm. And then this particular chap is having ptosis and Horner syndrome. There's so many mnemonics with respect to that Punjabi meal or whichever way you want to remember it. But TROP-IT negative was also given. Okay, fine. Considering the fact, doctor, it is myocardial infarction, this widening of mediastinum would not be present. So I good that you made that point. widening of mediastinum is again a feature that is seen with aortic dissection per se. So way the question is framed, it's a very classical presentation. As far as the chap with ptosis and Horner syndrome is concerned, and we can see a mass in the right upper zone of the patient, which looks like a lung collapse initially. This would be more in favor of a Pancoast tumor. I mean, why would not be an upper lobe pneumonia? The history is not corroborating with it. And when it comes to a lung aspergilloma, then I should be having history with respect to either immunocompromised state. I should be having, because it is going to be angioinvasive, so lung hemoptysis, lung aspergilloma can cause a hemoptysis. And yeah, doctor, we discussed that SVC obstruction will have a small sign coming up, or in fact, I'll say non-pulsatile elevated JVP that could be described in a patient with congested veins over the chest wall of the patient. So that makes it relatively easier for us. In case anybody has a different options, let me know. Otherwise, I think this was easier. Coming to the fifth one, there were a lot of discussion regarding this one also. Boy admitted with severe dehydration. Please confirm whether it was severe dehydration or thank you, Ashu, if that helped you. Would like to know whether the question mentioned severe dehydration or did the question mention circulatory failure, because that will change the amount of fluids. And in this particular chap, which is a standard presentation of diabetic ketoacidosis, I mean, the kid is having random blood sugar of 550, bicarbonate present of only 7 milliequivalents. So there is a acidosis component present. The trouble was, I mean, with these guidelines, I'll tell you, I mean, what these guidelines are. But before that, my point is only one. Did the question mention anything with respect to circulatory failure? If it is not, if it's moderate to severe dehydration, then the logic is like this. You have to incorporate a bit of pediatrics here. I mean, even in Ghai, when you read it, mild dehydration is about 5%. We take that, percentage wise when we classify mild, moderate, and severe. So it's 5%, then it's 6 to 10%, and then it's at least 10 or little more than 10% for severe dehydration. Considering the fact that we usually say, even in OP Ghai, we read severe dehydration when we're reading diarrhea, about 10% is the parameter that is used to quantify the magnitude of fluid loss. Total circulating fluid volume, 10% is depleted. So first and foremost, we'll think in terms of a fluid of 10 ml being given to this patient. Why I'm ruling a 20 ml is primarily because that would be given if the pulses are absent. I mean, I'll just highlight this once again. In case the question mentions circulatory failure, absent pulses, then I would have thought in terms of first I'll give a bolus of fluid so that I can make the pulse come back again. That would be 20 ml per kg. So that's one point. And the second issue is, should you be giving a bolus or should you give a insulin? Then, okay, potassium value given within normal limits. Great. If potassium is given to be normal, you can give insulin to the patient. The question would simply be, okay, in two options, 0.1 unit was not given. It was only give insulin after fluids. But I think the word after was very much there. So let me just clarify. Okay, maybe the dose is not given. I'll remove the dose from the final output that we generate for this. But the point is, if there is going to be management of a diabetic ketoacidosis, we first correct dehydration. And once we correct the dehydration, it will decrease the ketonemia, it will decrease the blood sugar also. And then subsequently, we can start the person on an insulin drip. So in this particular case, I mean, the afterward has to be taken into consideration. There are two options. One is 10 ml per kg, second is going to be 20 ml. So I'll just show you the reference also. The International Pediatric Society for International Society for Pediatric and Adolescent Diabetes is what they have come out with. The weight of the child was, I think, 30 kg. Okay. No, there is no controversy on this one, doctor. I'm just trying to resolve it. Even if the dose is given, it doesn't matter. As far as the guidelines are concerned, okay, slightly zooming out, this would be better. He says that if it is circulatory failure in a patient, that is when you give 20 ml fluid to be administered, and we need to take care of preventing and managing the cerebral injury in a person, because these patients can die because of the possibility of sir, this is not an updated or a great protocol. It is the standard protocol only. For any patient who's having diabetic ketoacidosis, first we give IV fluids, and after IV fluids, we then add insulin drip for the person. This is the standard protocol which is to be remembered. So there's nothing very great about it. It's the standard protocol only. The only thing is they have incorporated the name of those guidelines per se. But it's the standard thing. Even that one-liner question which has been asked in the previous NEET, they said what is the best treatment? Maybe the value in the previous NEET, or maybe one day before when we discussed, the value was 600. And even then it was discussed first IV fluids, and then it is going to be an insulin drip in a person. So the bottom line is the answer to this question will work out to be option number B. I've ruled out option number D in this case, where again afterword is given primarily because circulatory failure is not described in this question. So I would not call it a controversial one. And the logic that I understand it would be relatively a difficult one. The logic I'll use is severe dehydration term from pediatrics. When I read mild as 5% depletion, moderate is 6 to 10%, and severe is 10% or higher. So I'll think in terms of 10 ml per kg of fluid to be given to the person, and then subsequently I'll be giving IV fluids to the patient. So the afterward simply implies the fact insulin started simultaneously. No, doctor, it is not started simultaneously. No, when you say insulin drip in a person, first of all, I said you give IV fluid. The advantage of giving any person who comes to you with a thready pulse, let's put this clinically. If a person comes to you with a thready pulse, would you not like to first restore the pulse of the patient back to normal, ensure a better hydration, ensure perfusion of the kidney? And the advantage of giving fluid will also be that it will decrease the ketonemia component, it will decrease the blood sugar component by the dilutional effect also. It will also reduce the possibility of person dying because of cerebral edema, because there is a high osmotic load in a patient. So considering Dr. Manideep Yadav says mentioned good urine output. Doc, if he has written severe dehydration, then let's not make it difficult for ourselves. I mean, as long as you agree to this, okay, fine. Anubhav, I'll come to you in a while. Somebody said in the chat that you mentioned good urine output. If they mentioned severe dehydration findings, then I would go in favor of that. As far as Anubhav is saying that why not, 30 kg, that I have written, doctor, that I have written. Now, why not 20 ml? I mean, we can argue about it the whole night. As I explained to you, I mean, even by protocol, if a person is pulseless, the fluid bolus that you give is at 20 ml per kg till the pulse comes back to normal. And once the pulse comes back to normal, the fluid amount has to be reduced to 10 ml per kg per hour. Whenever you read about fluid resuscitation in a person also. And then we give fluid bolus initially to prime the insulin receptors. Priyanshu, as far as management of DKE is concerned, the main management of the patient is not a insulin bolus. The main management is giving insulin drip to the patient. In fact, I mean, this statement of mine that I'm saying, I mean, that is what I've emphasized in a routine treatment also. Because if you are saying that we're going to prime the receptors, that's not going to have a too much of an effect. It is just going to cause a bit of control of the blood sugar of the patient. You can achieve that control of blood sugar by administering you can correct that, I would say, the derangement of the patient's blood sugar and the ketonemia, or it can be reduced in magnitude by infusing IV fluids in a patient. So considering the fact, I mean, the way I think the justification that I provided is why I have not answered 20, no circulatory failure, no pulseless patient described in the case. And as far as why not I've talked about an insulin drip, because it would not make too much insulin bolus. Why I've not selected that option, because it's not going to change dramatically the status of a patient. What is going to change the status of the patient is an insulin drip, which is going to be given gradually. So the point is, any person with circulatory failure first, or patient comes to you severe dehydration, first correct severe dehydration and then initiate insulin drip in a patient, which is why I tried to justify this as option number B. Okay, Hardik, thanks for letting me know that the options are correct. I worked hard on them. Moving to the next one. The question talked about this 65-year-old chap who is an alcoholic, lots of alcoholics, and he was on aspirin therapy for 4 years. So I'll consider that as erosive gastritis. And once there is a erosive gastritis component present, then I'll think in terms of peptic ulcer disease. I know you will ask me why not a varicose bleed. For varicose bleed to be present on clinical grounds, I need to document portal hypertension, and for portal hypertension, I need to have a presentation of a splenomegaly. I mean, there is no evidence in this particular case of any liver cirrhosis. There is no caput medusae, no pedal edema, no spider angiomas described. And since the splenomegaly component is not given in this case, I'll put my money in this question on peptic ulcer disease. So again, you can see the oscillation part. I mean, one was, a tricky one. You stuck between 10 ml versus 20 ml. And for people who have talked about insulin bolus, let me reiterate my statement. The insulin bolus dose is not going to change dramatically the blood sugar values, because it's very negligible amount that you're giving subcutaneously to the patient. In any chap with a circulatory failure, आप सब दोगे भी तो फर्क क्या पड़ेगा सर? एब्जॉर्ब ही नहीं होगी, है ना? आपने दे भी दिया सबक्यूटेनियस, आप डीप सबक्यूटेनियस लगा दो, आईएम दे दो, फिर भी अगर सर्कुलेटरी फेलियर है, सो इट विल नॉट मेक टू मच ऑफ अ डिफरेंस. Then this particular question that I'm currently showing on the slide again has been widely debated. I'll show you the Harrison reference, but let me just read it out. The question said a person has undergone probably a transfemoral surgery. Do let me know if the word transfemoral surgery was given or it was simply that person is treated surgically for pituitary tumor. I'll be waiting for that in the chat. He is having a polyuria with a high serum osmolarity. So that tells me that in this particular case, there would be some amount of involvement of the posterior pituitary, and this posterior pituitary involvement is causing central diabetes insipidus, which explains why in this particular chap would be polyuria present and a high serum osmolarity because all the water is flowing out of the body. Now, in this particular case, we'll be using desmopressin. Should we give it on lifelong basis or should we give it for 2 weeks? First, I'll provide a justification and then I'll show you the Harrison reference. The justification is when you do a transfemoral surgery, you are trying to resect a tumor in the anterior pituitary. If a surgeon is so aggressive in his approach in resecting a tumor that it destroys the posterior pituitary, the benefit of the surgery would be lost. I mean, there is no point of operating in a patient. There is no point of operating on a patient where you do a transfemoral surgery and you give a lifelong pan-hypopituitarism to a patient. It doesn't make sense. I mean, the objective of surgery is that you should get rid of the tumor without causing a pan-hypopituitarism or damage to the posterior pituitary of the patient. So in this particular case, between A versus B, my first point is surgery इतना aggressive नहीं करेंगे कि posterior pituitary damage हो जाए. यहाँ पे मोस्ट ऑफ द टाइम यही हम देखते हैं कि ये जो डायबिटीज इंसिपिडस होता है ये ट्रांजिएंट होता है और ये क्वेश्चन थोड़ा डिफिकल्ट था इसलिए मैं आपको हैरिसन का रेफरेंस भी दिखा रहा हूँ जहाँ से मतलब इट्स नॉट कि मैं बोल रहा हूँ कि देंगे कि ट्रांजिएंट होता है. I mean, this is what Harrison says. और थोड़ा ये मुश्किल सवाल है कि transient diabetes insipidus and hypopituitarism can occur in a person because he has written this in the textbook. Whatever I'm saying is evidence based, guys. I'm showing you a reference for each one of them, whether it is CT angiography for subrectal hemorrhage, for which I showed you a Harrison reference, or whether I'm talking about this one. So in this particular case, what we need to do is initially handle this transient diabetes insipidus. Doctor will not use it Vaptans for 2 weeks. Okay, Vaptans for 2 weeks. Not an issue, doctor. Because we are talking about a chap who is Vaptan for some time. Okay, not a problem. I mean, let's not make it difficult for us because the person would be having a diabetes arginine vasopressin. Okay, got it. So this is not desmopressin. This is arginine desmopressin, arginine vasopressin that was in the options. But that still, okay, fine, doctor. The surgeon removed the tumor out of proportion. Fine. Even then, doctor, you see the operation is being done in the anterior pituitary. The operation is being done in the anterior pituitary, so posterior pituitary is adjacent to it. That's okay. But I'll say like this: the objective of surgery is to resect the tumor. Fine. We might have anterior pituitary hormone deficiency, but to have a posterior hormone deficiency would be medical negligence. It can be transient most of the time. So, yep. Based on the reference that I mentioned from the textbook, yes, thank you, Dr. Prakriti. DI and Vaptans for 2 weeks is what we need to answer for. No, it would not be. Vaptans would be answered. Yeah, that's my point. No? I mean, to give symmetry in the options. I think 2 options were lifelong and 2 options would be for 2 weeks. That would make much more sense. That is what Dr. Prakriti is talking about. Since person is having diabetes insipidus and that too of a transient nature, as I've explained to you, so I am going to be using in this case vasopressin derivative, which will tide over the crisis initially for medical negligence in this case. Well, as far as medical records are gone, if relatives will sue the surgeon, he can go back and show the textbook references that in almost 20% of the cases it's going to be transient and we are managing the patient appropriately. So I think we have a textbook reference for this instead of urine osmolality. Okay. Thank you, Dr. MA, for your input. I'll just take a snapshot of it at the moment. The bottom line is whenever a person is undergoing a transfemoral surgery, the benefit versus loss always has to be calculated. Yeah, doctor, I get it, Dr. Chaudhary. TSS was not given, but if he has mentioned about surgery for pituitary tumor, even if he has mentioned a aggressive surgery being done, max to max I will anticipate, because it's a anterior pituitary tumor, prolactinoma or acromegaly, that have acromegaly causing tumor, that would be resected, which is the common ones. Person can have a pan-hypopituitarism, but to expect him to develop a diabetes insipidus so severe that it's on a lifelong basis would be something that the surgeon has to be ready with a potentially a suit against him. Okay, guys, let's move on to the next one. Answer to 7 is sorted. The reference from the textbook is mentioned. Next one, I would love to debate with you regarding this one. A lady has anemia, fatigue, gum hyperplasia. Let me know, guys, your comments. Was it gum hyperplasia or was it gum bleeding? And meanwhile, I'll focus on the peripheral smear of the patient where we can see Faggot cells. Definition of Faggot cells would be that the oil rods would be more than 3 of them. And as far as the input that I got, I mean, the images were having a very large number of oil rods present. Okay. One option was about osmoreceptor. Ashu, you need to refine that, because that would cause gross asymmetry in the options which are present. I mean, we had options for 2 weeks, for lifelong, and then drugs which are being used. Okay, don't worry. Your answer would still remain the same. Doesn't matter, as long as we in pathology the diagnosis will be made on the basis of bone marrow aspiration, where we are gonna do a routine hematoxylin eosin examination, special stains, then a flow cytometry. So considering that the Faggot cells would be present, Anubhav says, what is the need of mentioning extensive surgery? True, doctor. But then the textbook does not agree to that, right? I mean, after all, questions are created with a textbook reference. So we can go beyond that also, and we can have a potential suit against a doctor. Like as I said, I mean, that would be a suit which he will have difficulty in wriggling out for. But considering that the questions are created from textbooks, difficult one, I'll say. For the previous ones, I was saying still okay, we can work it out. This one is, I would say, more of a bouncer kind of a question. So Anubhav, I agree to whatever you have said, but we have to take into consideration the textbook interpretation as well. Coming to this one, my point is, even if the question was mentioning gum hyperplasia, not a problem. As long as it was gum bleeding, DIC, not an issue. Gum hyperplasia is common with the M4 variety as M5 variety and M4 variety, but don't be under impression that gum hyperplasia cannot be seen in M3 variety. So first and foremost, I want to make it clear. Couple of guys said, sir, because that's the feedback I got. No, sir, in my paper it was gum hyperplasia. Even if it was gum hyperplasia is common with M5, M4, can be seen with M3. कहीं पे ये नहीं लिखा है कि it can't be seen with M3 variety. And how am I working out that this is M3 variety is with respect to the Faggot cells which are present here. So considering that oil rods are present in this case, the answer would be given as 15:17. And with respect to especially plain gum hyperplasia, the chromosomal translocation is gonna be is going to be answered as, I mean, if it was plain gum hyperplasia and the oil rods were maybe a single one, 11q23 is the chromosomal translocation which is present. So Shoaib, as long as it is gum bleeding, bleeding is a routine feature, right? With patients who are having acute myeloid leukemia, we get a thrombocytopenia in a patient. So we still have to base our diagnosis not on the basis of gum bleeding, not on the basis of gum hyperplasia. Our diagnosis would still be based on the histopathological image which is given in this case. Dr. Vidapu, I have already explained for baby or for child or adolescent, the standard treatment is IV fluids initially and then insulin drip only. DIC, I don't think so, doctor, was mentioned. If you are insistent, do let me know. I'll just wait for a few seconds for people to comment regarding whether DIC was written in this question or not. Personally, I don't think so. Gum bleeding, because he would base his question on the image. Like you are aware that, okay, when do you say a Faggot cell, how many oil rods should be counted and stuff like that. Ratan says M4 is related to inversion of chromosome number 16. That is what, Ratan, I'm trying to explain to you, that if it is M4, then the number of oil rods present in this cell is not gonna be the extensive appearance that is present. We do not make a diagnosis on the basis of either gum bleeding. We do not make a diagnosis on the basis of gum hyperplasia. We do not, I mean, DIC is a very characteristic feature, hardly seen nowadays because of the usage of, about ATRA, but then the bottom line is that if it's going to be extensive amount of fluid present, when it is going to be a extensive amount of iroids present, doctor, you jumped from a question. In those circumstances, okay, hepatosplenomegaly was present in the case. There were a lot of questions on hepatosplenomegaly, so I'm not sure whether it was given or not, but still, okay. The last comment was, okay, let me just cap this question 8 and I'll come back to what Dr. Vidapu said. M4 does not have so many oil rods is the logic to be used here. Considering the logic, if this is the kind of image which is what I have got, I mean the number of oil rods is extensive in the cytoplasm of the cell. We have to consider this as acute promyelocytic leukemia and therefore answer accordingly. And gum hyperplasia, gum bleeding do not change the answer, even if it is hyperplasia, even it is gum bleeding. Now, and DIC parameters were given. Even then, sir, no, sir. Even that will not change the answer. Even if it is gum bleeding, it will not change the answer. Gum bleeding is a feature in acute myeloid leukemia. Thrombocytopenia is anyway present, and if features suggestive of DIC, if features are suggestive of DIC, then it's okay. Okay, I'll come back to Dr. Vadapu. Doctor mentioned 20 ml of normal saline. Doctor, please check the guidelines once again. The guidelines are for 20 ml of fluid are for circulatory failure where pulses are not present. And in severe dehydration, we have a thready pulse. So please go back to the question. If it was severe dehydration, we'll go by 10 ml. That's a pretty reasonable amount that any routine physician would be comfortable giving or a pediatrician would be giving. And 20 ml is for circulatory failure. You can check the table once again, whichever discussion you have seen. Another question was, okay. Doctor, that will make asymmetrical aspects. Okay, Prakriti, I think we have sorted that. That one. And for somebody who again came to that, अमन पॉइंट इज न्यूमोडिपिन से रीब्लीडिंग थोड़ी ना रुक जाएगी अगर मान लो उसको 2 एन्यूरिज्म है, 2 मैं समझा चुका हूँ, सॉरी बिकॉज मे बी अमन जॉइंट लेट, आई एम आंसरिंग इस क्वेरी. मान लो उसको 2 बेरी एन्यूरिज्म है, एक फट गया और एक अभी नहीं फटा, कल फट जाएगा, तो आर्ग्यू करेगा ना रिलेटिव उसका, आपको बोलेगा ना कि डॉक्टर साहब अगर वो दूसरे वाला था उसकी कॉइलिंग कर देते आप तो सेकंड वाला एन्यूरिज्म बर्स्ट नहीं किया होता. एंड मोस्ट इंपॉर्टेंट, हाउ आर यू श्योर इट्स अ बेरी एन्यूरिज्म मैन? You need to identify na whether it's a berry, whether it is going to be arteriovenous malformation, or whether it is going to, I mean, where is it located as well. So for that is the reason why if you go through the notes also, CT angiography or conventional angiography is given. Dr. House, if it is in your paper, there is a possibility in the software that the same question can be twisted. 2 different people can be getting 2 different options. If it is circulatory failure, you can justify 20 ml. Nimodipine is for lowering the BP. It has a cerebroprotective effect. It has a cerebroprotective effect. It reduces delayed cerebral ischemia. Delayed cerebral ischemia develops after 48 hours to 7 days after an acute event. Prior to that, I want to handle much more adverse effects that I've explained. निमोडिपिन देके डॉक्टर साहब ओरल कैसे दोगे अगर मान लो वो कोमा में चली गई तो? निमोडिपिन तो ओरल देते हैं ना, और एनजी ट्यूब से देते हैं, एब्जॉर्प्शन इरेटिक होती है. इस बात को तो मानोगे कि अगर उसको बेरी एन्यूरिज्म है और आप उसकी कॉइलिंग करना चाहते हो, 2 एन्यूरिज्म है, 3 एन्यूरिज्म है, तो पहले कॉइलिंग करा दो, फिर निमोडिपिन दे देना जब ओटी से बाहर आएगा पेशेंट तो. ओके, मूविंग टू द नेक्स्ट वन. यस, नेक्स्ट स्टेप के हिसाब से प्रोटोकॉल पढ़ लीजिए, नोट्स में आपके दिया हुआ है. इट इज सीटी फॉर लंबर पंक्चर, NE2 पॉजिटिव, यू डू अ सीटी एंजियोग्राफी. चलो जी, अगले सवाल पे आते हैं. नहीं सर, इट इज नॉट मोलस्कम कंटेजियोसम. इट इज नॉट मोलस्कम कंटेजियोसम. मैं समझा देता हूँ सर, मैंने हैरिसन का रेफरेंस दिया, पेज नंबर दिया है यहाँ पे. HIV पॉजिटिव पेशेंट विद CD4 काउंट ऑफ 100 प्रेजेंट्स विद द फॉलोइंग लीजन्स, एंड यस द लीजन्स वर प्रेजेंट. आई मीन इट वाज अ इंडियन पेशेंट. सर अब इमेज तो मेरे पास नहीं होगी, तो आई विल हैव टू रिलाई ऑन. Okay, lung involvement present in this case. Fine, I got a feedback. Lung involvement नहीं था, but अच्छी बात है, lung involvement है तो और भी क्रिप्टोकोकस की फेवर में जाता है, but anyway कोई बात नहीं है. Okay, and CB-NAT is negative in this case. Fine. दो CB-NAT negative है तो tuberculosis का देने का तुक नहीं बैठता, but still चलो. Immunocompromised patient है, considering it is a immunocompromised patient and a lung involvement that is given, I will think in terms of either histoplasmosis or cryptococcosis in a patient. हाइलर लिम्फेडिनोपैथी डॉक्टर एक डिफरेंट क्वेश्चन में था. आई एम कमिंग टू दैट. आई एम कमिंग टू अ डिफरेंट क्वेश्चन जिसके चेस्ट एक्सरे में हाइलर लिम्फेडिनोपैथी था, तो हम उस क्वेश्चन के साथ इसको मिक्स नहीं करते. अभी फॉर दिस देयर वर 3 क्वेश्चंस सर, एज फार एज आई नो देयर वर 3 क्वेश्चंस ऑन इम्यूनोकॉम्प्रोमाइज्ड पेशेंट. एक तो जीरो वेसी था जो सब ठीक करके आए हैं, बाकी दो थी, एक एक जो था दैट वाज आई थिंक हिस्टोप्लाज्मा, उसका भी मैं रीजन बता दूंगा, माइक्रोबायोलॉजी बेस्ड क्वेश्चन था। वन डे बिफोर हमने डिस्कस किया था कि मैक्रोफेज के अंदर वो छोटे छोटे पैरासाइट दिखाई देंगे लंग लंग लिवाज के अंदर। एंड CD4 काउंट सर कुछ भी हो, देखो इम्यूनो कॉम्प्रोमाइज पेशेंट और स्किन इन्वॉल्वमेंट है, सो फर्स्ट इंप्रेशन तो हमारा यही जाता है इसको पढ़ के दैट द पर्सन इज हैविंग दिस अम्ब्लिकेटेड, आई मीन दिस इज द इनपुट आई गॉट, सेंट्रल अम्ब्लिकेशन in the lesions pearly white nodules which are present. Let me just zoom in, थोड़ा अम्ब्लिकेशन, ओके ये ऊपर वाले लीजन में थोड़ा अम्ब्लिकेशन है थोड़ा बहुत, बट द पॉइंट इज दैट दिस इज okay, HIV with tuberculosis, CB not negative, so it is skin tuberculosis. Dr. MA, you have a very valid point. uh, okay, we are having umbilical. सी हार्दिक, आई डो नॉट हैव द एग्जैक्ट इमेज, इंडियन पेशेंट था मुझे पता, ये तो गोरा है, ठीक है, दिस इज अ गोरा हेयर, बट कंसिडरिंग पर्सन इज हैविंग अ लंग इन्वॉल्वमेंट, तो पहला जो आपको सोचना है दैट इज ईदर जीरोवेसी और इट इज गोना बी क्रिप्टोकोकस, और जीरोवेसी में तो हमारी लंग इन्वॉल्वमेंट नहीं होती है। ट्यूबरक्लोसिस वाला पॉइंट हाँ किसी ने जरूर बोला है, आई थिंक इट वाज ट्यूबरक्लोसिस, तो somebody thought it would be skin tuberculosis in a patient as well। खैर कोई बात नहीं, I've given the reference of the textbook. This is not molluscum contagiosum. This would be cryptococcosis, which has similar identificational findings present. I mean that's a standard line again given in Harrison. So वहीं से हम उसको refer करेंगे। तो considering the fact, and ठीक है वो मैंने कर दिया सर, CB not negative वाला point I'll incorporate in a question subsequently. So I think between cryptococcus and tuberculosis definitely on, I mean the possibility of tubercular lesions would be present, but then tubercular lesions would be present most of the time on the buttocks if you're talking about skin TB, buttocks pay, and then over the face of a person. These are two common sites, but having extensive involvement all over, slightly unlikely. Sir, we diagnose, for saying why not histoplasmosis, I'll just say histoplasmosis per se does not produce skin lesions or does not produce these nodular classical lesions. The main hack is this particular line. Somebody said cryptococcus involves the lung. Yes, doctor, cryptococcomas first involve the lung. Even in you and me, if we go to a place where there are a lot of pigeon dust, pigeons present, and pigeon droppings are present in the dust, and we inhale that dust, cryptococcus first goes to our lungs. From our lungs, because we have a good immunity, cryptococcus is killed. But in immunocompromised patient, it can go to the brain. In an immunocompromised patient, the lesion can go to can disseminate to the skin as well. So that is why the answer what I have said. I mean the main hack in the question was he wanted to see that molluscum contagiosum versus cryptococcus to be worked out, and how to be worked out, because molluscum contagiosum would be a immunocompetent person, cryptococcus would be a immunocompromised patient, plus obviously lung involvement was given as a probable hint in this patient. Anubhav, my point against yours is only one: immunocompetent versus immunocompromised. I think that solves your point. Yes, yes, yes. Fine, MA. I think you got it. So it's okay. Okay. Let's move on to the next one. This alcoholic, he has presented, hi Meet, you did provide very good inputs to me, so thank you for that. Alcoholic presents with painful and swollen first metatarsophalangeal joint. Why not जीरोवेसी? सर जीरोवेसी का डायग्नोसिस जो होता है वो हमेशा ब्रोंकोअल्वेलर लेवाज पे बनता है. There was a separate question which I think the microbiologist has discussed, those black spots present, Gomuri methamine stain, and जीरोवेसी usually does not cause a skin involvement. It is Cryptococcus that causes a skin involvement. So that is why I am ruling it out. Okay. In this particular case, I knew that point. I wanted you to ask also that fever was present in a patient. Intracellular bodies, I'll just show you, doctor, subsequently when histoplasmosis would come. Those intracellular bodies would be present in a macrophage. So we are going to handle that. Okay, so fine. For this particular question, I expected a debate coming from you guys saying that this can be septic arthritis. Let me give my justification if I am reading this question for first time. Alcoholic with a swollen MTP. Aspiration shows increased leukocytes. Fine, leukocytes can be increased both in septic as well as in a patient who's having gouty arthritis. There is no history of travel, dysuria, dysentery. So as he has ruled out effectively reactive arthritis for me by ruling out dysuria, dysentery, sexual contact. He has ruled out pseudogout for me because pseudogout is mainly gonna cause involvement of the knee joint most of the time. So I am stuck between A versus B. Now in this particular case, serum uric acid is normal in the patient. Even if the fever is not given in this question, let's just resolve it first here. Serum uric acid is normal in acute gout. In fact, he could have even written in this MCQ, serum uric acid levels are low because in acute gout, in acute gout, uric acid is not elevated in the blood. During an acute attack, during an acute flare, serum uric acid levels tend to get elevated in the joint space and not in the blood. वो जॉइंट में प्रेसिपिटेट जब होता है तो ब्लड का लेवल नॉर्मल से लेस भी हो सकता है. सो वी डू नॉट गेट एलिवेटेड सीरम यूरिक एसिड. वी डू नॉट गेट एलिवेटेड सीरम यूरिक एसिड even in a chap who is having acute gout. The correct answer for this is option number A. थोड़ा बहुत फीवर भी प्रेजेंट हो सकता है. स्टिल दैट डज नॉट गिव आंसर एज सेप्टिक आर्थराइटिस. सेप्टिक आर्थराइटिस विल यूजुअली इन्वॉल्व द लार्जर जॉइंट्स ऑफ द बॉडी. Yes, yes, doctor. Call duty, that histoplasmosis image I'm coming to in a while. So there was an image given which will resolve this. Thank you, Dr. Singh. That second question on gout is, I think, for xanthine oxidase inhibitor. I think the pharmacologist has already handled that, so I did not touch upon that. Okay, fine, Gargi. Thanks for the input. No fever present in this chap. We'll seal this at acute gouty arthritis. The justification, Doctor, pseudo gout diagnosis will involve the knee joint, not the MTP. Point number one. To confirm pseudo gout, which is a diagnosis of exclusion, you need a joint aspiration positively by refrigerant crystals. Okay, Dr. Raj, you can send me your question, the one that you are talking about, the second one about gout. I think that drug part has been handled already. That is what I saw the pharmacologist discussing. Okay, then I think there was a congenital heart disease PDA, though this is beyond my domain. This would be a sixth aortic arch defect. And as far as, okay, doctor, okay, fine, MA, I'll try to do that. Then we have, fine, fine. Fine. Moving to the next one, we have this laborer. Please comment about the age group of the patient, and he is presented in an unconscious state with an elevated body temperature. Please comment about the body temperature in the patient as well. Anubhav, it can have any joint involvement, but it is always a diagnosis of exclusion. So we first should always think about common diagnosis, no? And then we should think about an alternative diagnosis in a patient. So, I mean, yes, you have a valid point, but at the same point, it can be negated on the basis of simple fact. Keep things simple. Okay, 105°F, and then the chap is having, you see, last year in 2021, when they asked this particular question, then the options were between sweating and bradycardia, and we had given the answer is bradycardia. Why? I'll just show you a table from Harrison which mentions this fact that sweating is not a very constant feature. No, Dr. Raj, it's not an exactly repeat question. In the 2021 question, I think that's the feedback that young doctors like you had given me. Sweating and bradycardia is what we had to select. So one, sweating is not a constant feature with respect to patient who's having a heat stroke. I mean, you could be having a diaphoresis, you could be having an anhydrosis, depending on the classical variety or exertional. If we gave you a scenario like, let me say a laborer working in Dubai in 50°C, and they're making all those buildings, right, high-rise buildings, and this guy is working in that extreme heat at 50°C, something like that. I would have thought in terms of that exertional heat stroke coming in, or with respect to athlete, if he would have given a description. But considering the fact that he has described this, okay, Vishal, thank you so much for that input. I did not have that. I'll save that. Right, but I think it can be still sorted out with respect to the distal part of the left aortic arch. The query of yours was that will be answer this for the left versus the right. So it is the distal part of the left one that has to be sorted. I hope that answers your query, Dr. Vishal. Okay, for this laborer, considering the fact that sweating is a feature which is to be answered best for this particular scenario, considering a 50-year-old chap working in the field, uh, exertion is a possibility, but yeah, the classical variety is one to be considered. Okay, moving to the next one. That's the Harrison reference for this one. 75-year-old lady does not talk to anyone, sits silently and looks at the sky on autopsy hippocampus. First thought process is there is aphasia present in the patient. Patient is, lost in virtual reality probably. And then I expected initially that Hirona bodies would be given, but he's mentioning about Lewy bodies. So I'll think in terms of Lewy bodies are seen either with Parkinson or with dementia with Lewy bodies. So I'll think in terms of dementia and Lewy bodies in this case. Do let me know whether visual hallucinations word were given. I mean, if it was given, it will make me more comfortable with answering this as dementia with Lewy bodies for this particular question. But if it is not given, even then let's evaluate this. Patient does not talk to anyone. Yeah. Okay. इफ विजुअल सर, अगर विजुअल हॉलुसिनेशंस होगा तो फिर तो सर डिमेंशिया विद लुई बॉडीज ही बनेगा ना। बट वो डिस्क्राइब कैसे करा, मतलब अगर क्वेश्चन में ये लिखा है कि पेशेंट डज नॉट टॉक टू एनीवन एंड सिट साइलेंटली, तो फिर वो पेशेंट ने मतलब बताया कैसे कि मुझे दिख रहा है, या मे बी इज मेंशनिंग एट लुकिंग एट द स्काई, तो पर्सन इज इमेजिनिंग दैट गॉड इज प्लेइंग होली इन द स्काई, समथिंग लाइक दैट, राइट? Prions were there. Okay, okay. Dr. Prion bodies were there. But sir, there are two questions. That bradykinesia, Anshu will come to that question. That's a separate one for the site of lesion. मैंने मेरा इसके बाद ही रख दिया मैंने वो वाला, जहाँ पे आप वो bradykinesia और वो slowness वाली description आप दे रहे हो, तो does not talk in history, does not expresses emotion. Okay, dementia with Lewy bodies यहाँ पर present नहीं है. Okay, Lewy bodies था biopsy में कि नहीं था? That is what I would like to know. ओके, थैंक यू आदित्य फॉर द इनपुट। डिमेंशिया विद लुई बॉडीज इज नॉट प्रेजेंट। फिर ऑप्शन बता दूं मेरे को थोड़ा सा। ओके, हंटिंगटन्स हो गया, प्रायन हो गया, पार्किंसन। हाँ सर, ऑटोप्सी नहीं है, हिस्टोलॉजी में मतलब हम डेथ के बाद ही तो ब्रेन बायोप्सी करेंगे ना सर, डेथ से पहले तो किसी का ब्रेन बायोप्सी नहीं कर सकते ना, तो ऑटोप्सी नहीं वर्ड होगा, मतलब पॉइंट है कि ब्रेन बायोप्सी कैन नॉट बी डन इन अ लिविंग पर्सन ना। तो यार लुई बॉडीज है इन द क्वेश्चन स्टेम एंड प्रायन वाज ओके। तो यार प्रायन में तो फिर वो होगा ना, PRPSC। ओके, इट इज पार्किंसन डिजीज, हंटिंगटन डिजीज, लुई बॉडी दिया है यार, सौमिक दास इज मेंशनिंग दैट लुई बॉडी, उसके बिना आंसर बनता ही नहीं है, यू नो। आई मीन वी विल हैव टू रिमूव वन ऑफ द अदर ऑप्शंस इन दैट केस। इट इज हंटिंगटन्स। ओके, पेशेंट सिट्स मोशनलेस। यार अगर लुई बॉडी है तो दो ही आंसर बनेंगे ना, या तो वो आई मीन अब तो सिंगल आंसर बनेगा, दैट वुड बी पार्किंसन डिजीज इन अ पेशेंट। ठीक है ठीक है, फाइन फाइन, लेट्स रिजॉल्व दिस। अगर यहाँ पे ये वाला है कि पेशेंट सेट्स, मैं रिजॉल्व करता हूँ उसका वर्जन 2 अगर क्वेश्चन कर लेते हैं, ठीक है। अगर ही सेज, अगर वो ऐसे बोलता है कि द दिस लेडी, आई मीन ही इज गिवन अ ओल्ड लेडी एंड शी सिट्स मोशनलेस, दैट मीन्स वो प्रोबेबली यहाँ पर एक एनीजिया डिस्क्राइब करने की कोशिश कर रहा है। सो as long as in the question Lewy body is present, diagnosis will be based on the basis of Lewy bodies only. पहली बात, Lewy bodies are a feature that is seen either with DLB or are encountered with Parkinson disease. If you say that person is having Lewy bodies and person sits motionless, तो फिर Parkinson disease हो जाएगा, तो टेंशन करने की जरूरत ही नहीं है यार आपको फिर ऐसे वाले केस में। और as far as hallucinations are concerned, hallucinations हो सकते हैं सर, even hallucinations can be present in Parkinson disease in a lead feature. So if clinical feature, एक मिनट बिफोर वी सॉल्व दिस क्वेश्चन एज पार्किंसन डिजीज, में अगला क्वेश्चन आपको दिखा देता हूँ। आप मुझे अगला क्वेश्चन पढ़ के बताना कि आर दीज क्वेश्चंस बीइंग मिक्स्ड बाय यू और नॉट, अगर नहीं है तो फिर आई विल कम बैक टू द प्रीवियस वन। वाइफ कंप्लेन्स दैट हस्बैंड इज नॉट टेकिंग इंटरेस्ट इन डेली एक्टिविटी, ट्रेमर्स एंड रिजिडिटी इज मोर। हो सकता है यहाँ पे द हस्बैंड इज okay, sits motionless looking in the sky. Okay, that is akinesia, doctor. Thank you, Dr. Krishna. Made things easier for me. Sits motionless looking at the sky. Considering that fact, I'll consider that as akinesia. Akinetic mutism is a feature that can be seen with both Alzheimer and Parkinson. The differentiating feature would be Lewy body. So, yeah, sir. There are two different questions. This one is gonna be talking about tremors and rigidity. Fine, got it. Fine. For this one, I am saying the question is fine. Prefrontal cortex versus basal ganglia. We'll answer this as basal ganglia. First one did not have. Fine, Ritvik. Fine, Ritvik. And we can solve this one still. Considering the four options that you guys have given me, I'll seal this as Parkinson disease. If it is not Parkinson, then dementia with Lewy bodies is to be considered. Facial hypomemia. Okay, thank you. Thank you. I'll add that. That means expressionless face in a person. The person will talk very slowly, and like when you talk to somebody you tend to have some emotions on your face, so that emotions patient would be affected. Okay, fine. So we are sorted for 13. If it is DLB is not there, as you guys are saying, we'll have to think in terms of Parkinson disease based on Lewy bodies. Okay, Dr. Krishna. Yep. So you took a very brave decision, and I mean I can understand the pressure that comes with leaving a seat, but believe me, everybody peaks at their usual time, so maybe this is gonna be the year for you when you would be peaking. it means the same, doctor. Expressionless face, facial hypomimia, they mean the same. You would not change the answer. So we have no issues with this one, 14th. We had some issues with 13th one. I really liked your enthusiasm while answering that. Okay, the next one was about, okay, alcoholic chap, loose motions. We'll think in terms of, you know, single 70 cc volume abscess present. So I'll think in terms of a amoebic liver abscess present. And what's the reason giving questions from repeated topic? Because these are the usual patients that come to the hospital. I mean, you go to the emergency and if you see the admission register of any government hospital, वही तो केस होता है सर, वही निमोनिया है, वही एमआई आ जाएगा, एक अमीबिक लिवर एब्सेस आ जाएगा, पायोजेनिक एब्सेस आ जाएगा. सो बिकॉज दोस आर द स्टैंडर्ड एडमिशंस, बिकॉज दे डील विद देम day in and day out, they tend to ask those questions. Okay, in this particular case, because it's a solitary abscess, I think everybody is agreeing to that, 75. So we'll give, I mean, we'll do a medical management in this case, in a sense that we'll be using metronidazole for this particular case. में कोई हिस्ट्री नहीं थी क्वेश्चन 14 में. ओके, डॉक्टर प्रकृति थोड़ा सा इलाबोरेट करना आपके कमेंट को. इस क्वेश्चन में कोई हिस्ट्री नहीं थी क्वेश्चन. आई डिडंट गेट इट द कमेंट. ओके, फाइन. So there is no point of reading rare diseases. Absolutely no, absolutely not. I mean, stroke, देखो मैं तो यही बोला यार, एमआई अच्छे से आना चाहिए, स्ट्रोक आना चाहिए, निमोनिया आना चाहिए. ये तो मतलब 3 बीमारियां हैं जो हर बार आती है ना. अमीबिक लिवर एब्सेस हो गया, हाइड्रेटेड सिस्ट हो गया. तो they are the common diseases that would be asked. And any patient having a amoebic liver abscess, we have to give metronidazole. यहाँ पे इतना बोल देना कि AIDS is given in the last video, सर उसको थोड़ा एक बारी देख लेना. So I think it will make it relatively easier. Sarthak, I do not have that AIHA and HS wala question, but anyway, I'll try if I can find it in this PPT. Why not pair? Okay, तो मैं ऐसे explain करता हूँ sir. First, the diagnosis of this case is not hydrated cyst. The diagnosis is not hydrated cyst. Hydrated cyst होता तो वो usually multiple होते हैं. पहली बात, any Indian patient who comes to you with pain in the right hypochondrium and a solitary abscess in the liver, you have to think in terms of amoebic liver abscess in a patient. ALA is the diagnosis. यहाँ पे pair तो सर करते हैं hydrated cyst के लिए ना सर. For amoebic abscess, Anubhav, a good question. Indications for percutaneous aspiration in amoebic liver abscess. दो सर्जरी का टॉपिक है, फिर भी एक्सप्लेन कर देता हूँ. If the size of the abscess in the right side is more than 10 centimeter and abscess of any side in the left side, क्योंकि left side वाला फटता जल्दी है, chances of rupture is there. So had this question always mentioned that there was a solitary abscess in the left lobe of the liver and maybe 4 centimeter, 5 centimeter, whatever, I could have thought it could have ruptured, man. I could have thought in terms of percutaneous aspiration to be done because it's gonna you know just pop off. And for the left hand side, more than 10 centimeter, as I said. So I think Dr. Luganathan, I am able to explain to you. And any patient amoebic liver abscess, first we give IV treatment, and then if the abscess does not resolve, the cavity does not collapse, and the size of the abscess goes beyond the values that I said, any size in the left side more than 10 centimeter on the right hand side, otherwise follow whatever the surgeon is saying. That's what we usually follow. We go in for a percutaneous aspiration in a patient. There is no history of loose motion in a patient. Even if I remove that, sir, even if I remove that loose motion thing, single abscess in an Indian patient with, you know, a liver abscess, solitary abscess, first answer is amoebic liver abscess always. Sir, the replacement, Abhilash, would be, you can go back in the discussion. I've talked about that. It is for 2 weeks. It's a transient decrease. It's not a permanent decrease. Yup. So instead of using metronidazole, we can give ornidazole in the patient. We can. Anubhav, no issues. I mean, as far as you are saying 5 centimeter, I said whatever surgeon is saying, we tend to usually wait. I think it's a range of 5 to 10 where we go for that. नो एबीजी, ईसीजी तो पूछा ना सर, एबीजी वो उसमें डायबिटीज वाले क्वेश्चन में डाल दिया, तो अलग से तो आई मीन इट्स समटाइम्स एम्स में पूछ लेगा सर, नेस्टी वाला. तो डोंट वरी, आई मीन द नॉलेज दैट यू हैव विल नॉट गो वेस्ट. दैट इज व्हाट माय पेयर का इंडिकेशन होता है सर. पेयर इज गिवन इन हाइड्रेटेड सिस्ट. पहली बात, पहले अल्बेंडाजोल देते हैं. अगर अल्बेंडाजोल से हाइड्रेटेड सिस्ट कोलैप्स नहीं करता है तो फिर पेयर करते हैं, और पेयर नहीं होता तो फिर सर्जरी करते हैं. तो ये पहली बात, दिस इज नॉट अ हाइड्रेटेड सिस्ट की प्रेजेंटेशन, दिस इज अमीबिक लिवर एब्सेस की प्रेजेंटेशन इन द सिनेरियो दैट इज गिवन. इंडिकेशन फॉर पेयर इज एल्बेंडाजोल से रिस्पॉन्स नहीं हुआ, और यहाँ पे तो हम एल्बेंडाजोल अभी बात ही नहीं कर रहे, मैं तो ऑर्निडाजोल की बात कर रहा हूँ, मेट्रोनिडाजोल की बात कर रहा हूँ। या नॉलेज इज पावर गाइस, पावर, वरना सीधा सरकारी अस्पताल में यार एब्सेस कौन सा आता है, मेनली तो हमें बिग लिवर एब्सेस ही आता है। ओके चलो जी अगले सवाल पे आते हैं। दिस इज द वन दैट यू गाइस वर टॉकिंग अबाउट नो, कि वो एक मैक्रोफेज है या एक मोनोसाइट है, उसके अंदर वो इंक्लूजन्स दिखाई दे रहे हैं। सो इन इम्यूनो कॉम्प्रोमाइज पेशेंट, आप एक दिन पहले का भी रिकॉल देख लेना, मैंने डिस्क्रिप्शन बताया था, आई थिंक 1 मिनट का डिस्क्रिप्शन था बिटवीन एस्परजिलस वर्सेस वर्सेस म्यूकर वर्सेस हिस्टोप्लाज्मा वर्सेस ब्लास्टोमाइसिस। आई एक्सप्लेन 4 of them इन अ मिनट और सो, एक बार देख लेना। Yeah, doctor, it's very normal to get confused in the exam. It happens with everybody, but it is like a law of average always keeps on working. Thankfully, God is there and He ensures for everyone wrong, there is one right. If it is pyogenic with E. coli, still it is antibiotic, doctor. And pyogenic, always remember, is multiple. Pyogenic abscess is never a solitary abscess. Here he mentioned 75 cc ka one abscess. So first we'll start with metronidazole in the chap or orindazole as the case may be, whichever is available. Okay, I does not talk to anybody. Okay, stares into space, visual hallucinations. Okay, fine. Sir, for Girovesi, Dr. Mir, we need a Goburi methamine stain. This is a hemotoxin, eosine, plus there is a mediastinal lymphadenopathy. So I think as somebody was saying, immunocompromised patient, chest infiltration, you have to think in terms of cryptococcus as well as think in terms of, possibility of histoplasma. How do you differentiate between the two? Cryptococcus will disseminate to brain or will produce skin manifestations, and histoplasma will cause mainly a mediastinal lymphadenopathy. Or for diagnosis, when you are gonna, this particular question, I'll say it's useless to try and evaluate the history part. I think the histological image is what is to be remembered. I think they mentioned a bone marrow aspiration that was done in this particular case, and this would be answered. Okay, one black arrow, one intracellular body. So we'll think in terms of this would be histoplasmosis. Okay, we are sorted for the 16th one, and let's move on to the 17th one, which is easier. Clonorchis sinuses would be causing, no doctor, for visceral leishmania, then we have to, BMA was given. Okay, Anand, welcome to the discussion. Visceral leishmaniasis, sir, he'll begin with the standard patient of resident of Bihar, West Bengal, anemia, leukopenia. We'll talk about presentation of a massive splenomegaly and not a mediastinal adenopathy. No? अगर आपको काला आजार सोचना है तो then it would be a massive splenomegaly which is to be considered. Okay, cholangiocarcinoma is what is sorted for this one, so I'll move to the next one. I think there were two informations for pain and one was inappropriate words. Inappropriate words mein P alphabet will come 3 times, so that's a score of 3. Eye opening with verbal response would be 2. And we're done with cholangiocarcinoma 1. I moved the slide fast because nothing to debate there. And my query to you guys for this one is, सर ठीक है, हो गया तो हो गया ना, फाइन. द पॉइंट इज, माय क्वेरी इज दैट दिस पेन वाला जो एस्पेक्ट है, वन इज आई ओपनिंग ऑन पेन स्टिमुलस, सेकंड इज विड्रॉल टू पेन. ये थोड़ा सा क्लैरिफाई कर देना यार, ये विड्रॉल टू पेन था या वाज इट abnormal flexion to pain or was it plain flexion to pain? Yeah, Limo, let's not rush into the answers in this case. Was it withdrawal to pain? Was it flexion? Or okay, withdrawal hai to withdrawal is going to be taken as flexion only, which is why the answer will be taken as 2, 3, 4 in this particular case. So as far as the withdrawal part is concerned, the withdrawal component is taken as flexion only. Histidine rich protein 2 dipstick would be used for falciparum malaria. That would be a easier one. So it's a mixed bag, as I can say. Let's take up the next one. Okay, as long as withdrawal is there, withdrawal is to be taken as flexion. You'll press on the nape of the neck of the guy or supraorbital notch, and he'll just move his arm. He'll not remove your hand. He can't localize pain, but withdrawal is withdrawal to pain basically means a flexion in the arm. Okay. So we sorted with falciparum, and then we had this patient from Delhi. And इसमें बस इतना बता देना मेरे को कि क्वेश्चन में कुछ ऐसा S4 वगैरह तो नहीं दिया हुआ था. Because maybe he might be talking about, okay, D was typhoid in a patient. Okay, so as long as S char is not described, we're not considering a Chigar point in the case. So that would be in thinking in terms of dengue only. Okay, 20 is sorted for at the moment. So pity dengue hi hoga. Right, right. For this question, I got two options. One option was tall tented T wave, and another chap said, no, sir, it was T wave inversion. Now, listen to me, let's not fight. In the software, there is a provision that when the examiner will frame the question, two different candidates could be getting the same question but in a different version. I mean, the question is the same, but the ECG will change. So, in your paper, if it was tall tented T waves, then it is obviously a hyperkalemia. But if you're having a T wave inversion, if you're having a roller coaster kind of a ECG, roller coaster would mean that there would be a T wave inversion. Let me just sketch it. And then there would be a U wave present, so that T wave inversion and then the U wave is referred to as a roller coaster appearance. Then the answer will change to that of thiazide group of diuretics. So let's not fight over it. I mean, that is a possibility. And I've taken into consideration both the scenarios because I got tall T waves as the first input. Then a doctor interrupted me. He said, no, for me it was a roller coaster ECG. I said, fine. Then the answer will change over to thiazides. So not a problem. Okay, fine. For 21, I am not sure, sir, what NB is doing or what the current board is doing. That is what I thought, that the software has these provisions of swapping the images for the same question. Okay, fine. So I mean, how will they justify that, or how would that be taken into final counts? I have absolutely no idea. I was just speculating because I got an impression, I got a suggestion from a doctor that he did not have tall T wave. So I said, fine, then your answer is justified if it's a T wave inversion. Then we had this chap who consumed 100 tablets of aspirin. I mean, that's outrageous, but 10 patte. No, that's pretty outrageous. But then aspirin would be acetyl salicylic acid. It will contribute to metabolic acidosis. So I need to handle that metabolic acidosis with soda bicarbonate. And in those circumstances, okay, lavage is not there in the options. फाइन फाइन बोल देना या फिर ऑप्शन बता दो मेरे को डी का ना एनेसिटाइलसिस्टीन तो बी ऑप्शन था डॉक्टर लोगनाथन आई थिंक इट वाज स्टमक लेवाज ओके ECG image quality. Okay, let's focus at the job at hand, guys. I mean, let's not get into it. Soda bicarbonate with urinary alkalinization. So, doctor, I think that gives me more confidence to answer this as now more appropriate, because I was wondering soda bicarbonate, why is it not mentioned? It's only urinary alkalinization present. So it's okay. Okay, the answer was alkalinization. That's mainly to handle the metabolic acidosis component. And I mean, you get metabolic acidosis with respiratory alkalosis in these patients, which is the reason why. Okay. Fine. Moving on to the next one. Okay, so it is soda bicarbonate for urinary alkalinization, which is to be answered. The next question, I mean, for the language part, this is what I got. I want to know if this word disequilibrium was mentioned or not. If it was, then things will become okay. HCN was the fourth option there. Okay. Thank you, doctor. Ashish, that would not change the question. I mean, soda bicarbonate is used for urinary even if urinary alkalinization word is not there, doesn't matter. I mean, soda bicarbonate is gonna cause that. We'll give it obviously lesser dosage for urinary alkalinization. Okay, as long as dialysis disequilibrium is used, मैं concept समझा देता हूँ. The point is there would be cerebral edema developing in a patient because जब आप dialysis करते हो fast, तो rapid shift होता है fluids का. और ये रैपिड शिफ्ट्स ऑफ फ्लूइड्स अक्रॉस द ब्लड ब्रेन बैरियर की वजह से सेरेब्रल एडिमा हो जाता है. द बेस्ट एग्जांपल आई कैन से इज लाइक दिस कि डायलिसिस करना तो 4 आवर्स था और आपने डायलिसिस ज़्यादा कर दिया या अग्रेसिवली कर दिया. If you do too much of dialysis in a patient, it will cause rapid fluid shift across the blood-brain barrier, and that can trigger development of cerebral edema in a patient. So what I can do in this case is I want to reduce the sudden shift in osmolality of plasma. I mean, the concept behind disequilibrium is that when the patient came, osmolality of plasma was very high. And after your dialysis, the osmolality became lesser than normal. So that sudden fluctuation of osmolality has to be prevented. To prevent that sudden change of osmolality, we can be using mannitol in the patient. He was diagnosed as dialysis. Okay, fine. That's what I wanted to know. I mean, dialysis disequilibrium, how do we say any chap who's having CNS features after dialysis? It means that it was done, I mean, there was a sudden gross change in osmolality of the plasma. Urea contributes to plasma osmolality. So we shall be in that particular case using mannitol to reduce the cerebral edema component. The main logic is rapid fluid shift. पहले osmolality maybe 320 330 था, अभी decrease करके 270 हो गया in a matter of few hours once the dialysis session was over. So because of this fluid shift, I want to minimize that fluid shift in a patient. Okay. Okay, Nasiritide is one of the options here. Fine, fine. Though I highly doubt that, but still, I mean, since you are saying I'm incorporating that. High potassium in the patient. Dr. Paresh, can you just comment about high potassium for this particular question? I mean, he mentioned that he's having high urea and high potassium. Okay, that's what you mean. Okay. That's understandable. That would be indication for doing dialysis. If blood urea is going 100 milligram percent or even higher, though we tend to have a lower threshold, but if blood urea is 100 milligram, potassium is very, very high, we'll be doing a dialysis in a patient. Okay, not furosemide, it is Nasiritide. Okay, doc, not an issue. See, Sunil came up with a T-wave inversion thing, so I don't dispute that, doctor. If it was T-wave inversion, no problems. I mean, then you will say, fine, the chap would be having thiazide as responsible for. I think Dr. Sunil is mentioning about the previous question. Okay, let's move on to the next one. It's sorted for 23. No, Dr. Nasiritide would not change the answer because that would be causing natriuresis. So it will rather worsen the scenario of the patient because if I lose fluid further, the osmolality of the plasma will change dramatically. So, and P wave absent. Okay, Paresh Panda says P wave absent. That gives more credibility to hyperkalemia, doctor. Uh, Prakriti says T wave inversion was there. That's why I'm saying, doctor, there is a possibility. I mean, if there is a T wave inversion, the whole question is bouncing in a different direction. Okay, let's solve this one. I'm having a patient who's having a thyroid problem, and this thyroid problem patient is also having atrial fibrillation. So first he is asking me, what will you treat first? Will you first treat the thyroid problem, which is gonna be a long-standing problem, or will you first treat atrial fibrillation? Because I know atrial fibrillation will cause, fast beating heart can cause congestive heart failure. Fast beating heart can contribute to cardiac issues which can be difficult to control. Even if you don't control them, they could be tachycardia induced cardiomyopathy in the long run, plus there is risk of clots going into the brain of the patient. So if I'm having a thyroid problem and I'm having a cardiac problem, I will first treat the cardiac problem of the patient and then treat the thyroid swelling in a patient, which is why I am ruling out propylthiouracil and propranolol for this particular case. Yeah, I'm gonna use that, definitely yes, but at this particular point of time my objective is not to handle the problem of the patient from the perspective of handling uh, the thyroid issues. My objective is to handle atrial fibrillation, and what would be I more comfortable with than considering that a chap is having atrial fibrillation, I can use beta blocker, but because asthma is given in a question, I'll be more comfortable answering this as diltiazem because यहाँ पर asthma का problem दिया हुआ है. एंड क्या कार्डियो सिलेक्टिव यूज कर सकते हैं, तो वो आई थिंक यू आर अवेयर कि कार्डियो सिलेक्टिव जो होते हैं वो 100% कार्डियो सिलेक्टिव तो नहीं होते ना, उनका थोड़ा बहुत एक्शन रहता है. ए फिब इज ड्यू टू थायराइड ओनली सर. Okay, I can understand that, Ritvik. AFib is due to thyroid. I agreed, doctor. AFib is due to thyroid problem only. But first, okay, but the first thing is if esmolol is totally not selective, what is the use of making it? Sir, not all patients are asthmatic. No, esmolol is a short acting. What is the use? Okay, Anubhav, I'll give you a very good reason why have they made esmolol. Atrial fibrillation causes hypotension. Na? ये तो मानते हो, BP is gonna be 90s, 80s. If it decreases to 70, 60, person will become unconscious. Esmolol has an advantage that it is a short-acting beta blocker, so it will prevent the dramatic fall in blood pressure for a very long duration, which will be impossible to handle. So the advantage, beauty of esmolol is it will control the heart rate, but will cause a minimal decrease in blood pressure for a minimal duration, which is gonna be the advantage to me. So that is, I mean, since you are saying that what is the advantage of making that drug, I gave justification that hypotension component would be less pronounced with esmolol. Okay. And when it comes to, I mean, asthma, we do not use asthma, we'll prefer using diltiazem in the patient. PTU is an emergency drug. No doctor, it's not an emergency drug. And otherwise तो यार IV तो है ही नहीं ना preparation, वो तो NG tube से देते हैं thyroid storm में. If it's gonna be thyroid storm in a person, then you have to give PTU IV to the patient. But if it's atrial fibrillation, then first we'll have to be considering that. No doctor, it will not be considered as a thyroid storm in a case. It will be atrial fibrillation due to hyperthyroidism in a patient. Commonest arrhythmia that occurs after sinus tachycardia in any patient with thyroid disease is atrial fibrillation, especially because it's secondary. Okay. Yes, Dr. Loganathan, you were right. We need a AV block in this case, so we can be using CCB in a person. My point is simple. We need rate control. Rate control can be either with esmolol or with the diltiazem. The point against cardioselective beta blocker or any beta blocker per se, propranolol तो खैर देना ही नहीं है. You understand asthmatic है. But point against esmolol is again that it's not 100%. Nothing is 100% in pharma. Dr. Rahman, I agree. You can consider thyroid storm on the basis of most of the time thyroid storm presents with elevated body temperature, hyperthermia. Thyroid storm presents with features of congestive heart failure. So considering hyperthermia not described, congestive heart failure not described, features of dehydration not described in a question, I would be a little more skeptical thinking in terms of thyroid storm. I agree to what you're saying. Thyroid pace, we'll think in terms of thyroid storm. Agreed to that. Point against thyroid storm, hyperthermia should be there, congestive heart failure should be there, dehydration would be present in a person, and that's because he's breathing so fast, he's losing, his basal metabolic rate is accelerated. So I think it would be same as last time, doctor. Okay. Patient presents with a prominent A wave in the JVP. I know your query will be why the answer is not mitral stenosis. Then for mitral stenosis, for large A wave to be present, you need it to be long standing. Because if you have a long-standing mitral stenosis, you then have a pulmonary artery hypertension, then pulmonary artery hypertension can contribute to right ventricular hypertrophy, and then subsequently that A wave would be developing in a person. So considering that this would be a prominent A wave, I'll give benefit as that of tricuspid stenosis. So this was a repeat one. For 26, I had only one comment in the initial chat which I initiated in the group. So only 1% commented about this MCQ. So for history, there is pulmonary edema and crepitations. Okay, that's a news for me. Breathlessness in a patient. Okay. TR is very much there. Sir, TR causes CV wave, no? TR causes CV wave, so that would not be answer. Okay, breathlessness in a patient. Yes, go on. Breathlessness, what else? Okay, before we come to that, Shubham, let's go back to the previous question. Dr. Blue said breathlessness. Sir, breathlessness can be present in any cardiac lesion. That is mainly a feature of the fact that in tricuspid stenosis, less blood will be going to lungs. But breathlessness does not mean pulmonary edema, na? Breathlessness is not always due to pulmonary edema. अगर किसको tricuspid stenosis है तो इतना तो agree करते हो that in tricuspid stenosis the blood going to the lungs will be lesser. Sir, I can justify. Sir, if CREPs are present, then the answer is definitely not going to be tricuspid stenosis. Absolutely not. If there is going to be, if this particular question is going to be mentioning regarding presence of CREPs and mentioning about pulmonary edema, then the answer is definitely not tricuspid stenosis. Then the answer would be mitral stenosis. So I mean, just बात बदल दिए, वो वाला जो डायलॉग है वो वहां पर एप्लीकेबल हो जाता है. Hi Maraj, how are you? Been seeing you very long. Okay, fine. Let me resolve this. My take on this question is the way I have written this question. Prominent A wave. That's the feedback I got कि सर simple JVP का question था, physiology based. हमने तो सोचा भी नहीं कि medicine based question है. That's one of my dear students told me. He said कि सर prominent A waves था, मैं tricuspid stenosis mark किया. Yeah, doc, large A wave, prominent A wave would mean the same. Canon मत बोलना please. Okay, Dr. Rehanshi says this would be a mid diastolic murmur. See. Cutoff, sir, it's difficult to say at the moment. Let's not speculate. Things will become clearer as days progress and more people start talking about how many corrects they got, then we'll get a fair amount of idea. Sir, peripheral edema goes in favor of. If you're talking about peripheral edema, I'll write that data in red. If you're talking about peripheral edema, that goes in favor of right side of the heart, peripheral edema. So I'm giving you two versions. Okay, okay, Dr. Blue, as I said, I mean, there's permutation combinations are present. If there is pulmonary edema present in a case, your answer is definitely correct for mitral stenosis. You do not get a pulmonary edema with tricuspid stenosis. Absolutely right. I mean, I think even the day before this, we were talking that if check in the question for cardiogenic pulmonary edema. If it is present, you have to answer as a mitral stenosis. So no dispute upon that. The point is, depending on whatever language you got, your answer would be appropriate. Okay, let's move on to the next one. If it is peripheral edema, Sunil, as I explained, then it goes in favor of TS only. Na pedal edema हो जाएगा ना right side का the heart involvement पे. Yeah, Krebs was in a taco. Yes, yes, yes. But I don't have the taco wala question. But okay, I'll add that subsequently. चलो जी अगला कर लेते हैं. We have this patient who's presenting with fever and meningeal signs. थोड़ा सा describe कर दो कुछ age group, duration of history that was given. Dr. Yashoda, no problems. You just need to send a mail to PrepLadder, or you can take my email ID marvamedicine@gmail.com and let me know your problem. I think it should be resolved. It's not a big deal. Thank you, Dr. Kadam. Let's focus on the job at hand. Otherwise, we'll go to chit chat. Child presents with fever and meningeal signs. थोड़ा help कर दो इसमें मुझे थोड़ा duration वगैरह बता देना मेरे को. And then CSF findings of neutrophils are present with low sugar and increased protein. मतलब I'm wondering इतना easy सवाल भी पूछेगा. Okay, gram negative, pleomorphic. Okay. Yeah, herpes simplex encephalitis MA, we are coming to that. That's the next question. We're coming to this. Herpes simplex encephalitis are coming to. My query is, did we have a question? No, sir. I think they gave bacterial details. Options were different. Was not present. Okay. Okay. Fine. Fine. The way the question is given. Okay. So hemophilus, gram negative. Chalo, fine, Anand. We'll skip this. We'll skip this one. And Anand, do let me know the options subsequently. Once we finish this discussion, please मेरे को एक बार type करके भेजना, please. Age of the बच्चा was also given, must be given, ना? Okay, options were related to bacterial culture and he was asking the organism पर से. बच्चों में most common तो यार अगर वो neonate पूछ रहा है फिर तो gram negative होता है. Adult में तो नहीं होगा ना? या बच्चे में तो नहीं होगा. It would be pneumococcus only. या hemophilus, right? Hemophilus influenzae. That can be one of the reasons for meningitis in children. Shubham, if it was present, the answer is pyogenic meningitis. If it is a child, तो बच्चे में even if it is a micro based question मैं solve कर देता हूँ. बच्चे में दो कारण होते हैं meningitis के. Child की बात कर रहा हूँ, neonate की बात नहीं कर रहा हूँ. Leading cause of pediatric meningitis is pneumococcus. Suppose in microbiology options, pneumococcus was not in the options, then you have to answer as Haemophilus influenzae, which is a leading cause of development of meningitis, which even causes development of deafness in the question. So okay, even if you mix it with microbiology, it makes sense. I mean, these are the two common organisms. Gram negative मैंने क्यों बोला? Because gram negative will be for neonates. So 5-year का बच्चा है तो no issues. You know, if this is gonna be a 5-year-old kid for pyogenic meningitis, these are two options that I will be considering. It is for neonates that I have to consider, no? Especially in an Indian scenario, though we know that neonate is gonna be group B streptococcus, and then it's gonna be gram negative organisms like Klebsiella, Acinetobacter, E. coli. So that's where the gram negative organisms would come. Okay, sir. Maybe the surgical indications would be there, but first and foremost, if he says what would you do initially, then initially we'll anyway give IV antibiotics to the patient. It is later on that we do a percutaneous aspiration. Okay, maybe the volume criteria are given somewhere. Otherwise, I think it is abscess measured by size and not by volume. Okay, moving to the next one. The Q SOFA components. Okay, Pritesh sir gave medical management as answer. Not a problem. Fine. Moving to the Q SOFA components. I mean, heart would be involved, lungs would be involved, and brain would be involved. So that would solve the job for you. I mean, the systolic blood pressure, the GCS of the patient, and the respiratory rate is to be considered. Okay. Then for herpes simplex encephalitis, there were two questions. One was talking about the diagnostics part. Then the answer will change to be slightly different. that would be, I mean, how do you diagnose herpes simplex? We do a PCR antibody test with, I think so, somebody mentioned that, or Zank smear. The point is, if it was antibody based test, then antibodies take time to appear. So though in this particular case, IgM antibodies would not be developing immediately. So maybe after a week I can go in for antibodies if they are present. Then is, भाई लैंग्वेज ऑफ द क्वेश्चंस है ना कि दैट वुड डिसाइडेड, तो इसमें इतना परेशान होने की जरूरत नहीं है. सीमेंट फैक्ट्री वर्कर यूजिंग हैवी वर्क, पेंट जॉब, कंप्लेंट्स ऑफ वाइट फिंगर्स, तो वो रेनॉल्ड्स फिनोमेनन हो गया उसको. इसको हैमर हैंड बोलते हैं. एनबीए शुड रिवील क्वेश्चंस. क्वेश्चन नहीं यार, अब तो आंसर की देना चाहिए. नो सर, दिस वुड नॉट बी एस्बेस्टोसिस. इन दिस मीजोथेलियोमा वाज प्रेजेंट. इन द ऑप्शंस था ना मीजोथेलियोमा. आई थिंक आप क्वेश्चन के साथ मिक्स कर रहे हो. मैं एक्सप्लेन कर देता हूँ. जो लोग मेट्रो में ड्रिलिंग, जो मेट्रो का टनल बनाते हैं और उसमें वो ड्रिल मशीन यूज़ करते हैं, या जो क्रेन ऑपरेटर होते हैं, या जो पत्थर हैमर से स्टोन्स को ब्रेक करते हैं, तो जो हैमर हैंड जो टर्म होती है, दैट इज फॉर रेनॉल्ड्स फिनोमेनन इन अ मेल पेशेंट, और उसकी वाइब्रेशन इज द मेन रीजन फॉर इट. सर metronidazole was not in the options. No, it was medical management. It was not metronidazole. We can give ornidazole in a patient, sir. So mesothelioma was a different question there, sir. Okay. Fine. The answer to this one is vibration. I've given justification for the same. I mean, why am I saying that this was mesothelioma? Nahi hai, sir. These are totally a different options that are being considered. He works with paints. That is okay. Even in सर ड्रिलिंग मशीन है ना, हैवी मशीनरी या ड्रिल मशीन की वजह से आंसर है. वाइट फिंगर्स आर रेनॉल्ड्स फिनोमेनन. हैवी मशीनरी का जो वाइब्रेशन होता है, आप इसका सोल्यूशन मैं ऐसे बोल सकता हूँ. हिंदी में स्क्लेरोडर्मा पढ़ लेना. स्क्लेरोडर्मा में जहाँ पे मैंने रेनॉल्ड्स फिनोमेनन डिस्क्राइब किया है, वहाँ पे मैंने बताया ये कि रेनॉल्ड्स फिनोमेनन मेल पेशेंट में कहाँ पे मिलता है, तो कंस्ट्रक्शन वर्कर में मिलता है. सो वहाँ से ये क्वेश्चन जो है वो सॉल्व हो जाएगा. ओके जी. देन इज बायलैटरल हैमरेज इन टेम्पोरल लोब. तो ये रूटीन हम डिस्कस करते ही हैं. टेम्पोरल लोब की इन्वॉल्वमेंट होती है जब भी, और साथ में ब्लडी सीएसएफ होता है. दैट इज ऑलवेज अ फीचर विद हर्पेस सिम्प्लेक्स एन्सेफेलाइटिस. व्हाई नॉट बाइसिनोसिस एंड बागासोसिस? क्योंकि सर इसको वील कॉल दिस एज द सेकेंडरी वैरायटी बिकॉज देयर इज अ रीजन प्रेजेंट. इडियोपैथिक को प्राइमरी बोलते हैं. डॉक्टर इमासिक मे बी आई चैट वेंट अप. Somebody said primary बोलेंगे, secondary बोलेंगे. Primary is the idiopathic variety. Okay. Sir, if you are having that older subscription, so everything is same as was for the previous years. There is gonna be no change present. At least मेरे phone में तो चल रहा है sir. Okay. Bilateral hemorrhage temporal lobe, that would be herpes simplex encephalitis. Finger white है sir, वही लिखा मैंने ना. White finger से लिखा मैंने ना. वाइट फिंगर ऑप्शन में था सर. अनलाइकली है वाइट फिंगर ऑप्शन में होगा. इट इज मेनली द कॉज ऑफ इट दैट वाज आस्क्ड. द बेसिक कंसेप्ट सर सवाल का यही है कि रेनॉल्ड्स फिनोमेनन प्रेजेंट है मरीज में. हैमर हैंड बोलते हैं इसको. आप हिंदी वाले में सुनेंगे तो आई थिंक आपको थोड़ा क्लैरिटी आ जाएगी. yes doctor, yes I agree to that. We will also work on that, solving that mycology part. I will try to focus on that. Maybe put up some videos on YouTube, half an hour to 1 hour, on the core aspects which need to be remembered. HIV medicine, sir, HIV always comes. मैं तो बोलता हूँ 2-2.5 घंटे का वीडियो देख लो भाई. थोड़ा सा ओरिएंटेशन बेटर हो जाएगा. चलो अगला सवाल कर लेते हैं. आई थिंक दैट वुड बी द लास्ट वन दैट आई हैव फॉर द स्लाइड. चेंज ओल्ड वीडियोस इन हिंदी. चेंज कर दूं क्वेश्चंस को सर? चलो कहाँ हटा रहे हैं. चलो okay. 30-year-old patient with chronic hepatitis B and hepatitis E positive with viral load of 10⁵ copies per ml. viral load ज़्यादा है सर, मतलब indication for treatment is 2 × 10⁵ viral copies per ml, and doubling of SGPT is indication for treatment. The main treatment that we need to start in this patient for I got answer is pegylated interferon. सर पेगालेटेड इंटरफेरॉन के इंजेक्शन लगाने पड़ते हैं ना. विद इंजेक्शन द प्रॉब्लम इज मेनली कंप्लायंस. आई मीन इफ यू टेल समबडी कि 6 महीने आपको रेगुलरली क्लिनिक पे आके इंजेक्शन लगवाने हैं, तो कंप्लायंस विल बी रिलेटिवली पुअर. प्लस आई मीन द टॉलरेंस पार्ट वुड आल्सो बी रिलेटिवली बैड. there is a table which is given. I have simply explained this as like this. मैंने ऐसे बोला है कि viral load is more than this, तो tenofovir को start करना होता है. How did I arrive at that? I have arrived at this from a table in Harrison, जो कि मैं आपको अभी यहाँ पे दिखा रहा हूँ. I mean, for most of the questions I've given textbook references. उसने ये mention ही किया हुआ है कि lamivudine तो आजकल हम use ही नहीं करते हैं और adifovir भी use नहीं करते, no longer preferred. विद रिस्पेक्ट टू पेगालेटेड इंटरफेरॉन, ही हैज मेंशन्ड कि उसके टॉलरेंस स्कोर होती है, वो मैंने बताई आपको. कंप्लायंस इश्यूज विल बी वेरी वेरी मच दे. या आंसर इज ए अनुभव, आंसर इज ए. एंड द पर्सन विल बी यूजिंग टेनोफोविर well managed in this particular case, and that is what I explained. Okay, surface antigen positive, sir, no, not an issue. Yes, it is surface antigen positive and E antigen also positive. Two things were positive. Okay, I'll minimize it. Surface antigen positive and, okay, zooming out slightly, and E antigen positive. Yes, doctor, the answer is A for this one. Tenofovir will be used. That is the drug of choice which is to be administered. Okay, absolutely, absolutely. So some of them are going to be straightforward one, and great, Dr. Krishna, you have anyway, I mean, been there, seen that, so you are more expert at that understanding that pressure situation. Question was there on dialysis. Nikhil, I do not have that question. I would request you to send me that at this email ID, and I'll provide you with inputs. So in case you find some gross differences in the options, please feel free to ping me at this email.